Thank you very much. It's an absolute pleasure to be here with such a full audience. So the question that Ronnie Chang posed to me, I gave him a totally different title for this talk, but he said, I've changed your title. Why has Hong Kong done well? So I decided to act like a politician and answer a question I could answer rather than one that I could not. So I decided I could answer the question, why has the USA done badly, better than I could answer the question, why has Hong Kong done well? So I don't know the answer, but I think I know where to look. And so the linked question is, why has the USA done badly? I can't see this, but perhaps you can. If we look at life expectancy for men and women, 1960 to 2015, there's Hong Kong. So there was Japan. Japan did extremely well fairly early. So you've got to go back to the 1960s for Japan and the US to have the same life expectancy. And the US improved. Cuba now has longer life expectancy than the US. That's not the greatest foreign policy success of the US, but that's not a very high bar. But Cuba now has longer life expectancy than the US. Japan continued to improve. And Hong Kong, as the chair just said, now exceeds Japan. Dramatic improvement. Just for contrast, we've got the Russian Federation. When I started looking at these figures, particularly in Europe, what we saw was not just the Soviet Union, but all the communist countries of Central and Eastern Europe had worse life expectancy than Western Europe. And this is not a political statement. This is not a statement of whether I think communism is a good or a bad thing. What I can tell you is what was happening in the communist countries was bad for people's health. And to say that's not a political judgment, that's a health judgment. It wasn't working. And if you take, for example, think of the Austro-Hungarian Empire. If you take Austria and Hungary, in the 1950s and 1960s, life expectancy was equal in Austria and Hungary. Austria was part of the West, Hungary was part of communist Central and Eastern Europe, and in the 70s and 80s, Austria looked like Western Europe, life expectancy getting better all the time. And Hungary looked like the communist countries, and life expectancy wasn't getting better. And then in the Soviet Union, when it collapsed, life expectancy collapsed. So the Soviet Union was very bad for people's health, and what happened next was even worse. And finally, there seems to have been some improvement in the Russian Federation, but it's a long way behind. And I think this is all largely social and economic. So comparing females, the UK, the USA, and Hong Kong, life expectancy at birth, there's Hong Kong. US doing very badly, UK kind of middling, not brilliant, but kind of middling, but the USA doing very badly. Males, UK, USA, Hong Kong. This is really dramatic. I said I don't know much about Hong Kong, but we did a report for Taiwan a couple of years ago. And the striking thing in the data from Taiwan is we see what I call the social gradient in health that I've been observing in Western countries for a very long time. This is mortality, age-standardized mortality rates by level of education. University, junior college. That's really interesting. I'll say to the students, it's not enough to have a bachelor's degree, you've got to have a PhD. And if you're not working on your PhD, don't listen to me. Go off, and it's good for your health. And senior high, it's a remarkable social gradient. It's not just that poor people have worse health than rich people. It's a gradient. It's inequalities, not poverty. And for each educational group, those who had no job in 2000 have higher mortality than those who had a job. So you have gradient by years of education, and then the effect of unemployment. Working is good for your health, provided the quality of work is good. United States, this is life expectancy at age 50 by year of birth. People who were born in 1920 will be 50 in 1970. People who were born in 1950 will be 50 in 2000. And this is by deciles of income. So 10% of income. This remarkable social gradient, the higher the income, the higher the life expectancy at 50. And what happened over this 30-year period is people in the poorest 10% got a tiny improvement in life expectancy at 50. People in the next 10%, a slightly bigger improvement. The next 10% bigger, 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 bigger. So the social gradient got steeper, the inequalities got bigger. Wow. Now, it's lunchtime. You may be feeling a bit drowsy, not quite robust. Are you ready for this next slide? Are you feeling strong? Okay. I've given this informed consent. You've said you're ready to see the next slide. Women. Life expectancy is going down for the bottom 10%. It's going down for the next 10%. It's going down for the next 10%. The bottom 30% of the income distribution, life expectancy at 50 is declining for women. And then, the richer you are, the bigger the increase. The inequalities are getting massively bigger in such a short period of time. Something is going terribly wrong. And as I said, I think I know part of the answer to the US. It doesn't mean that what Hong Kong's doing right is the opposite, as it were, of what the US is doing wrong. But as I said, I think I know where to look. One other figure from the US, this is incarceration, race, and parents' income. The lower the parents' income, this is white men, the greater the likelihood of being in prison on any one day, and that's black men. Look at this remarkable social gradient in incarceration. On any one day, at the bottom income group, the very bottom income group, 22% of black men in the United States are incarcerated. And incarceration per se has dramatic impact on health and life expectancy. People who've been in prison have shorter life expectancy, in part because of what got them into prison in the first place, but in part because of the effect of incarceration. They don't get jobs when they get home. Their families are disrupted. It's difficult for them to become part of the community. And it's not just older people or younger people. This is middle-aged. If you look at all-cause mortality, age 45 to 54, from 1990 to 2012, France, Germany, UK, Canada, Australia, Sweden, mortality is declining in all of these countries. Big differences between France and Sweden. There's US Hispanics, looks like the UK, and there's US non-Hispanic whites. Mortality's going up. And the causes, number one, poisonings due to drugs and alcohol, the opioid crisis. Number two, suicide. Number three, alcoholic liver disease. The authors of this paper, Anne Case and Angus Deaton, call it deaths of despair. Deaths of despair. The lower you are in the hierarchy, and those deaths of despair are distributed by years of education. The fewer the years of education, the higher the increase from these deaths of despair. And life expectancy in the US has declined 2 years in a row. In fact, this is up to 2016. I think it declined again in 2017. And look at the rise in unintentional injuries, and they include accidental drug overdose. 63,600 people dying of drug overdose, largely opioids. Go into a typical American school. If you're a 15-year-old boy, count 100 boys just like you, 13 of you will fail to reach your 60th birthday. Is 13 out of 100 a lot? The US risk is double the Swedish risk, which is less than 7. In Hong Kong, it's 6.4. Looks like Sweden, slightly better. So that's probability of dying between 15 and 60. That's not old age. And if we look at some comparisons of the UK, US, and Hong Kong, adolescent birth rate. We don't think it's very good for adolescents to have babies. And in fact, it's not good for the health of the baby or the mother. The UK, 14.6 per thousand. The US, 22.6 per thousand. Hong Kong, 3. I think that's a measure of good health of society, the fact that girls are not having babies. Paid maternity leave, statutory paid maternity leave. In the UK, it's only 14 days. In fact, women get longer, but it's only 14 days statutory. In the US, it's 0. US is not the only country that has no statutory maternity leave. Suriname and Papua New Guinea. 3 countries have no paid maternity leave. And Hong Kong is 70 days. That's saying something important about society. Young people, 18 to 24, not in education or employment. 11.9% in the UK, 16.5% in the US, under 7% in Hong Kong. Homicide rate, 0.9 per 100,000, 3.9 per 100,000, 0.9. Incarceration per 100,000, 146, US 698 per 100,000, Hong Kong 114. Incarceration rate. And as I've said, locking people up has dramatic impacts on their health and expectation of life. And Hong Kong has a low rate of incarceration. I think it's telling us something important about the health of the society. And the US is an outlier. In most wealthier nations, maternal mortality rate is dropping. South Korea, Germany, Japan, UK, Australia, Sweden. I haven't got Hong Kong, but I'd be surprised if it didn't look like Japan, the decline in maternal mortality, and the US is going up. How many women should die of a maternal death? None. No woman should die of a maternal death. We know how to prevent that. I gave a lecture to the American Gynecological and Obstetrics Society, and I said to them, if you tell me that you deliver the best obstetric care in the world, I have no reason to disbelieve you. Why, though, do you have such a high maternal mortality rate? And my guess is, I said to this audience in the US, if I asked you to write on a piece of paper who the women are who died, you'd all write variants of the same thing: the socially excluded, illegal migrants, the poor, single mothers, and the like. In other words, the social determinants of health intersect with access to and availability of medical care. And it's not just money. I'm in the process of completing a commission for the Pan American Health Organization on equity and health inequalities in the Americas. So this comes from the Americas. If you look at gross domestic product per capita at purchasing power parities, adjusting for purchasing power, there's Haiti, Bolivia, Brazil. At low levels of national income, a higher income nationally is associated with improvements in life expectancy. But when you get up to here, Costa Rica, Cuba, Chile, at around $17,000, and go all the way out there to the United States at $59,000, there's just no relation between national income and life expectancy. Canada has national income a quarter less than the United States, and life expectancy that's between 2 and 4 years longer for women and for men and for women. So it's not just a matter of getting rich. Getting rich is quite convenient for a country, if you're down at this level. But once you get to that kind of level, getting richer is not the solution to getting healthier. It's addressing the social determinants of health. I wrote a book, The Health Gap. I wrote a book, The Health Gap. The opening lines of which, why treat people and send them back to the conditions that made them sick? When we get sick, we want access to high quality health care, and we will all eventually get sick. And we all want access to high quality health care. But it's not lack of health care that led to us getting sick in the first place. And why treat people and send them back to the conditions that made them sick? It was translated into Japanese, into Korean. I won't bore you. And I've been chairing commissions which have been gathering the evidence on social determinants of health. And that's why I say I think I know where to look. I haven't looked at Hong Kong, but we'd like to. But I think I know where to look. So I chaired the WHO Commission on Social Determinants of Health. And we said on the cover of our report, social injustice is killing on a grand scale. We said empowerment of individuals and communities, and indeed of whole countries, is important. In the wake of the WHO Commission, the British government commissioned me to do what became known as the Marmot Review. How could one country, England, apply the findings of our global commission to make recommendations? The European Review of Social Determinants and the Health Divide. So these were the recommendations from my English review. And that's why I say I think I know where to look. Number one, give every child the best start in life. Number two, education and lifelong learning. Number three, employment and working conditions. Number four, that was really radical. For the fifth richest country on the planet, we think everybody should have enough money to feed their children, should have the minimum necessary for a healthy life. Number five, healthy and sustainable places to live and work, housing, communities, and so on. And number six, taking a social determinants approach to prevention. So I'm going to touch on these because I think it's potentially highly relevant to the Hong Kong situation. That's why I say I think I know where to look, because I didn't arrive at these conclusions just sitting in my bath. We got, for the WHO Commission, we had scores, if not hundreds, of experts from around the globe giving us advice. For my English review, I had something like 80 experts in different working groups summarizing the evidence. So this comes from a great deal of deliberation. Give every child the best start in life. One way of doing that is reducing child poverty. here we've got child poverty defined as less than 60% median income for the rich countries. Denmark, Iceland, Norway, Finland, child poverty is around 9 to 10 to 11%. Japan, it's gone up. I mean, South Korea, it's 11.5. It's higher in Japan now, 18%. The UK, just under 20%. The US, a poor country, 29% of children in poverty, just below Mexico. The level of child poverty is a political decision. The Minister of Finance has his hands on the levers that can change the level of child poverty. The US is quite tolerant of child poverty. The Nordic countries and South Korea and Japan, less so, are intolerant of child poverty. So they change the tax and benefit system to get low levels of child poverty. And that will set the trajectory for the rest of those young people's lives. Poverty by age in Hong Kong, less than 50% median income from the Oxfam report, just over 20% for people 15 or less, somewhat less in middle age, and quite high at older ages. Now, I haven't got the data in a comparable form, so that's part of what we should do, is to look at child poverty in Hong Kong compared with other countries. And I've mentioned South Korea and Japan as interesting comparators. UNICEF looks at 4 dimensions of child well-being: material, health, education, and behaviors and risks in early childhood. And there's the UK and the US equal bottom out of 20 countries on these measures of well-being in early childhood. In the late 2000s, the UK went zooming up to number 16 from the bottom, and there's the US. I do like lecturing in the US about this topic. It's the only big country that makes me feel halfway decent about my own. Beginning of life doesn't go well in the United States, and there are huge inequalities. Homicide and bullying. Homicide age 0 to 19, bullying age 11 to 16. Iceland, Italy, Greece look the best. And, oops, the United States looks the worst. Neonatal mortality, suicides, mental health, young people, drunkenness, young people, and fertility, age 15 to 19. So a measure of adolescent health and well-being. Chile, of these rich countries, is at the bottom, and there's the United States, 5th from the bottom. Early childhood doesn't look good. Adolescent health doesn't look good. Child poverty doesn't look good. Education. Finland always does the best in Europe. These are PISA scores, Program of International Student Assessment. So global tests for young people age 15 on mathematics and reading. These are the mathematics results. There's Finland, best in Europe, and that's the social gradient by the economic and social classification. There's the UK. Our best don't quite do as well as the Finnish best, and a steeper social gradient. There's the US. It's rather miserable. Don't do very well, and a very steep social gradient. There's Macau. I haven't got figures for Hong Kong, but Macau, my goodness, now does better than the Finns at the top. China has overtaken Europe, or at least the figures that we have. Very important. Employments, I'm not going to talk about all of this. You've got other things to do today, so I skip over 1 or 2. poverty rate, regional and world trends, and there's East Asia and the Pacific. Now, of course, that's a reduction of poverty in China. And global poverty has gone down, largely because of China, but not exclusively. There's sub-Saharan Africa, it's still very high, but it's gone down. South Asia, it's gone down dramatically. There's the world. Latin America and the Caribbean, it's gone down a bit, and we're bumbling along here at the bottom. So dramatic. We should not take global poverty as a given, and particularly East Asia and the Pacific shows what's possible. And of course, Hong Kong has been part of the beneficiary of that. A less progressive tax code in the US. I'm talking to business people who probably think a less progressive tax code is a good thing. Well, for you it might be, but it's not necessarily good for the ability of government to spend money to reduce child poverty. And the US has got a lesser progressive tax code. There's the top 0.1%, which had an increase in the tax rate over this period, but over the longer haul, it was a reduction. And then, of course, Trump's recent tax cut, all the benefit went to people of higher income. And rapidly rising pre-tax inequality in the US. There's the cumulative change in income adjusted for inflation by income group, the top 0.1%, the top 10%, the middle 40%, and the bottom 50%, really no improvement. No improvement. So early childhood education, income for the bottom half of the population. I think I've got some explanations from our research as to why the US is not doing well. Rankings on social spending, health spending, and life expectancy. So the US ranks #1 on health spending of these countries. But on social spending, Sweden's #1, and the US is way down there. And on life expectancy at birth, Japan, I haven't got Hong Kong on this, Hong Kong's up there, and the US is way down there. So they spend a lot on healthcare. They don't get much for the money. They spend a good deal less on social spending. It's a bit complicated, but what was in those slides that I skipped over is that if you think of the United States as the land of opportunity, social mobility, it ain't true. Social mobility, the chance of getting to a higher income group than your parents, is less in the United States than in virtually every European country. I don't know what it is in Hong Kong, but it's an important issue. Does the society create opportunities? If your parents were poor, are you destined to be poor? That's more true in the United States than it is in any European country. And strengthen the role and impact of ill health prevention. These are English data looking at childhood obesity by deprivation decile. The least deprived, the most deprived at reception and year 6. Look at this dramatic social gradient in childhood obesity. Now that will track through into adult obesity. And if you think that obesity is caused by people making poor decisions, they've only got themselves to blame. Hang on, these are little children going into reception class. Don't blame them for their poor decisions. Blame them for their choice of parents, perhaps. Those children were very irresponsible, choosing parents who were too poor to give them good food. What a terrible decision to make. Choose rich parents, for goodness sake. Look at this. In Britain, Public Health England gives healthy eating advice. If you followed the healthy eating advice and you were in the bottom decile of income, household income, you would spend in England 74% of your household income on food. You'd have to live on the street because you couldn't afford rent. Or if somehow or other you're in a house, you couldn't heat it. You'd have to choose between eating and heating. And we blame people for making poor choices. What? 74% of total household income would go on healthy eating. Impossible. And in the second decile, it's still 28%. That's a great deal. Whereas in the top decile, it's only 6%. They can afford to eat healthily. And I can't resist putting this in. More guns, more gun deaths. Whoop! They say, the National Rifle Association says, guns don't kill people, people do. The only solution to a bad guy with a gun is a good guy with a gun. Now, how many times have you heard that? That's garbage. The US has 300 million guns. How many more guns do you need? And guess what? The more guns, the more homicide. The more gun deaths, suicide and homicide. In my English review, we were dealing with Uzbekistan and Kazakhstan and Kyrgyzstan, countries that were doing very little on any kind of social investment, any kind of attention on social determinants of health. And we said, if you're doing nothing, do something. It'll make a difference. If you're the Czech Republic or Poland or Hungary and you're doing things, but not that much, do more. And if you're Norway or Sweden and doing a great deal, do it better. There's something for everybody. And now I'm going to quote somebody, do the unpardonable, quote the chair of the PAHO Commission on Equity and Health Inequalities in the Americas. And I said, at the heart of the Commission's purpose is ensuring the right of all people in the Americas to lead lives of dignity and enjoy the highest attainable standard of health. We call on all governments to act. Thank you.
Well, Michael, my brother is right again. I'm sorry. Not only is very interesting material, but your presentation is fantastic, right, ladies and gentlemen? And a round of applause. Can I ask a trivial question? Not quite trivial, but how many of you are UCL students or UCL parents or otherwise associated with UCL? Please raise your hands.
Oh.
Okay, you got it. Okay, floor is open. Question from anybody. I surely have a lot of questions, but I will obviously give you the first crack, in particular the student at the back, okay? Who's going to be the first?
Did I notice in the adolescent thing that New Zealand was incredibly bad? Is there a specific reason for that?
I'm sure there is. I think part of the issue is 15% of the New Zealand population are Maori, and the situation of Maoris in New Zealand pales compared with non-Maori, and I think that's part of it.
I think he's right, I'm afraid. Okay, the gentleman by the window.
So you talked about parents making wrong choices, kids making wrong choices of parents, and the amount of the affordability of food. Now, the interesting thing is that processed food is actually cheap.
Sorry?
Processed food is cheap. And that seems to kind of play into the stuff that you talked about, because a lot of times the only affordable food is processed food. Processed food has a lot of sugar, Coke. I don't want to take names, but let's say the fizzy drinks, they're cheap, and people have access to it. sugar taxes seems to have worked in Mexico. Would you kind of advocate things like that to redistribute some of that, make it more expensive, take that tax and get people to, eat healthier food?
Yeah, I'm troubled. So on the whole, I've supported consumption taxes as a way forward, but they're regressive. And particularly, look at tobacco tax. I've supported it, but in most countries, the poorer you are, the more likely you are to smoke. So consumption tax on tobacco or sugar-sweetened beverages is going to have an adverse economic impact on the poor. And when I've said that, people say to me, don't spoil a perfectly good tax by concern with equity. We can deal with the equity issue some other way. I said, do you ever do that? No, that's just words we use to shut up people like you. So I think consumption taxes in general are a good way forward, and I've certainly supported a sugar tax. It makes a modest difference, but still it's important. But then we need to make sure we deal with the equity issue somehow through some other mechanism.
In front.
Thank you very much, Professor Marmot. I'm a huge fan of yours, so I've read your book, and I've been preaching about your Whitehall studies around Hong Kong. So it's really great to meet you. There is a question I've always had in mind that's quite relevant to the Hong Kong context, because looking at life expectancy, I think it's very clear in terms of quantifiable years, but we've learned about the healthy life expectancies as well. I've been trying to look into any rankings that look into the healthy life expectancy, taking into account both qualitative and quantitative life expectancy, because I know that the Institute of Health Metrics, they do DALYs, but it's sort of looking at a disease perspective. Would it be interesting to look at the healthy life years across countries? Because in Hong Kong, unfortunately, towards the older years when I was working in the hospital, we see that especially older patients, they go back and forth between elderly healthcare homes and the hospitals because we don't really have advanced directives, advanced care plans. So they're sort of in a suffering, and they might not want to be that. But yes, their life expectancies is increasing. But in terms of quality of life, unfortunately, it seems it's not that optimistic. So I'd like to hear from you from that perspective. Thank you.
Yeah, I use life expectancy as an indicator, not that I think the only thing worth having is another year of life. It's an indicator, a crude indicator, but it's an indicator of health. Citing the UK data for the moment, what we see, if you classify neighborhoods by degree of affluence, the more affluent the neighborhood, the longer the life expectancy, a remarkable gradient all the way from the bottom to the top. And then if we do it for disability-free life expectancy, it's a much steeper gradient. Much steeper gradient. Colleagues at the Chinese University of Hong Kong showed me this morning that Hong Kong ranks right up there, number one, life expectancy, but on functioning and frailty in older life, Hong Kong, I think it was 80-something out of 99 countries, whatever. It was quite low. So you're absolutely right. It's not just length of life. It's quality of life, particularly for older people. So I use life expectancy as an indicator, but it's a crude indicator. And clearly what's important is quality of life, not just length of life. And Hong Kong doesn't do quite as well for that. And the inequalities are steeper.
As a Hong Konger, I had wanted to live longer. Now I realize maybe I don't, unless you guys change it, okay? Martin now.
Thank you, Professor.
And then Ted Lippman.
Thank you for the very impressive presentation. It certainly contains a lot of information that I'm not aware of. There is one specific question. I can see that the USA is the highest spender on health. I mean, in terms of public expenditure, I suppose. But the health results is not the best in the world. I mean, just look at the maternal, the mortality rate. So does anyone know the reason for that? I mean, you spend the money and you don't get the results. So why is that?
Well, I think that a couple of things. Firstly, the terminology you use is the common terminology. They talk about expenditure on health, when in fact they really mean expenditure on health care. And health care doesn't solve the problem of inequalities in health. It's important, but it doesn't solve the problem. And when I was talking about maternal mortality, and I said the women who die are the socially excluded, the illegal migrants, the wives of prisoners or the partners of prisoners, and so on. And so the social determinants are key influences on the kind of care to which you get access. And I've been reading lately about horror stories of what happens, particularly to African American women, when they get into the care system. And doctors fail to recognize preeclamptic toxemia. We know this is utterly preventable. No woman should die of toxemia in pregnancy. No woman should die. And they failed to recognize preeclamptic toxemia because somehow these are poor women and they don't matter, or God knows what's going on. But in other words, the social and economic determinants of health are intersecting with people's access to their health care. That's quite apart from the fact that I claim I'm not a political person. Before Obamacare, 16%, 1 in 6 Americans did not have health insurance. They did not get access. That 16% went down to 11%. So that's an improvement, more Americans getting access to health care, but it's not like being in Canada, where the lack of access to health care is zero. If you get sick in Canada, you get access to health care. That's not true in the United States. So they're the social determinants that determine people getting sick. They're the social determinants that influence access. And then there's the fact that the poorest 10 to 15% don't get health care at all.
Okay, Ted, sorry, that gentleman got the microphone already. She didn't listen to me by not listening to me. So please listen to me, okay? That gentleman first and then Ted.
Thank you, Professor. As you said, given us a very, very good framework to look at least with 6 areas. As you mentioned also that Hong Kong has been doing quite well. We got one of the best maternal mortalities, or like an unemployment rate has been very, very low. What is the one piece of advice as a Hong Konger that you would give us that we have to look at first, or one of the most important way to look at like equity issues? In health, we do have many, many problems. What would the number one problem that you had that you think we should do first out of the health equity issues that we're talking?
I was in Australia recently, and on a previous visit, the day I arrived, a journalist said to me, "We've spent billions of dollars trying to close the health gap between Indigenous Australians and non-Indigenous Australians. It hasn't worked. What should we do?" And I said, "I'm jet-lagged. I just arrived. You've spent decades thinking about this problem. Give me till tomorrow, and I'll tell you tomorrow." So I'm tempted to say the same to you. I arrived at 1 o'clock in the morning. I've just started thinking about Hong Kong. Tomorrow I'll tell you what the number one issue is.
Ted?
You just said God knows what's going on, which kind of begs the question, why doesn't he do something about it? But it kind of segues to another aspect of research that may not be something you're doing directly, but I wonder if you're aware of whether a spiritual practice of any kind, of any religion, has any effect on longevity, regardless or maybe in spite of economic and other more quantitative factors that you are measuring?
It's a very interesting question, and I'm aware of research. I am aware of research on the question, but the answer is equivocal. And one of the reasons the answer is equivocal is because, in general, it's correlated with belonging to a community. People who have religious practices and spirituality, in general belong to a religious community. And belonging to a community tends to be supportive. So whether there's something in addition about spirituality, the literature is not clear. So it's been looked at, but I don't think there's a very clear answer.
Gentlemen, and then
So Michael,
in front.
you say that in your last slide that health is a human right. And so the underlying causes are the problems. So popping a pill from a psychiatrist or a psychologist or doing meditation just helps temporarily. It's a kind of Band-Aid, and it's the social underlying causes of the problem. And for example, in the UK, you've lost all your CABs, you've cut out the whole of legal aid. So the human rights of homelessness, unemployment, bankruptcy has caused this vicious circle of stress or living in poor conditions causing asthma. And so Dame Hazel Genn has started her study to talk about law, public health partnerships, things like that. So legal help, whether it's free or by a subsidy, can help try to address the human rights so people can go back to more sustainable homes or have their asylum dealt with in a better way. So I wonder whether you can maybe cooperate with Dame Hazel at UCL to deal with those issues.
Well, I've been I was going to say a reluctant convert, but I've not been reluctant, I've just been slow to taking a human rights approach. My initial statement was, if we accept a human right to health, then we have to accept a right to the social determinants of health. Exactly along the lines that you said. And then I said rhetorically, we know, I showed you figures for PISA scores at age 15. If somebody doesn't do well on a PISA score at 15, then they have shorter life expectancy. A right surely entails a responsibility. Whose responsibility is it to make sure young people do well at age 15 in school? And so I left that rhetorical question hanging. Now, with our PAHO commission, we had several lawyers among our commissioners, and they convinced me that there are human rights instruments that will really help this along the lines exactly of what you just said, thinking about housing, access to education and the like, and that there are human rights instruments, certainly in the Americas, that are actively being used. So I'm a convert, an evidence-based convert. Yes, I think we need to work with people who are active in pursuing human rights.
Dr. Tamaslow?
Professor, a wonderful talk. I wonder, in the future, if you conduct research using data of Hong Kong, will you look at the Chinese medicine and related cultural factors? Thank you.
I think it's very interesting. And talking to colleagues at the Chinese University of Hong Kong this morning, what they said to me, and this is secondhand, I say I just arrived, this is secondhand, but what they said to me is there are a lot of popular myths about Chinese culture and life in Hong Kong, and we shouldn't, like filial responsibility, looking after older people and the like, and they said we shouldn't take these for granted. They should be looked at, because I have to confess, I subscribe to those. I didn't know they were myths. Looking after older people.
Are you Chinese?
But, you know, it seemed to me they're good things. And I'm prepared to go along the lines that community cohesion, intergenerational cohesion are very important positive factors. I'm open-minded about, is that really true or is that exaggerated? But I think we need to look at it. I think it's of vital importance.
Any more? At the back, that's Franklin Lam, one of the top researchers on Hong Kong society.
So Michael, I always believe that to have a fair society, you need to have minimally do two things. The first one is the provision of good education accessible to every child.
Yeah.
The second one is to catch every sick person when he or she falls, irrespective of personal means. That being the case, I was very happy. One of the things I'm proudest about the 20th century is that after the Second World War, the National Health Service was created in Manchester, where I graduated from. And I quite like this, even though whether you're a socialist or capitalist, it doesn't quite matter. But I think catching every person when he or she falls is like a duty of every citizen. Now, the question I raise is, of late, as the population of the world ages, there is more and more worry that all these social universal healthcare systems are overladen with expenditure. Now, the question, and one of the things that I think Hong Kong is not doing well is that we are using the queuing system. So if there are more patients, then the time it takes for every patient to get looked at is lengthened by multiples over the last 5 years. But we have the money to pay for it. But somehow, I'm not so sure what the resistance has been, but people are very slow in doing this. As if to say, if we were to make the queuing shorter, well, there will be a lot more people coming in as a freebie. Now, is there some statistic or facts that we can chuck to people to say that actually, as society ages, is absolutely right and fair to devote more resources, even at the expense of increasing public taxes, to fund this? The same question is now hitting the NHS, of course. I think overnight they have got some kind of statistics to put UK in terms of cancer scanning at number 33 out of 38 countries in Europe or something. So how come the creator of a universal healthcare system in the world is still not meeting the challenge of putting more resources into something which universally been accepted as fair? And Hong Kong is a derivative of that trend.
Well, I agree with your original observation about the fundamental importance of education and of healthcare. I think there's some other things too, and in my list of 6. What I would do is build on what you said and say, yes, indeed, we do want to catch people when they fall, but we want to do more than that. We don't just want to catch people when they fall, we want to promote good health. You heard from Mr. Chan about health and happiness at the Harvard Chan School. That's promoting good health. It's not just catching people when they fall, it's helping people lead flourishing lives. You notice in my conclusion from the PAHO Commission, I said leading lives of dignity. I didn't say catching people when they fall. I don't know if it's true. Some people argue that if we can prevent illness, we would reduce healthcare expenditure. I don't know if that's true, because it might be that we increase healthcare expenditure because people survive to older age and they get arthritis and the like. So we could, whether we decrease healthcare expenditure or we increase, it's worth doing because you're creating the capability to lead a flourishing life. So it's worth doing. And for a rich society, we do have enough money, if we want to spend it, to pick people up when they fall. So we need to decide. I mean, when Adair Turner did his inquiry into pensions in Britain, and he wasn't thinking about healthcare, he was thinking about income for elderly people, he says, pretty easy, really. We can have older people be poorer. We can have working age people be poorer by putting more money aside for pensions, or we can work longer. And society's got to make that choice. Do they want older people to be poorer, working age people to be poorer, or work for longer? He didn't say we don't have enough money. We just have to make the societal choice of how we want to use societal resources. And I think that relates to your question.
Last question, Dr. Anthony Chan from Chinese University.
So very quick question, Sir Michael. So a lot of new healthcare expenditure has actually gone into non-evidence-based healthcare. Is that very well quantified to show that that doesn't improve health? I think the best case in point is the US, obviously. So if that's made very clear to governments and business leaders, they might actually change the mindset of introducing more and more competition which, is usually a good thing. But in healthcare, sometimes it just drives non-evidence-based medicine. Would you like to comment on that?
Yeah, I mean, there's some evidence from the US that competition drives up costs because the consumer's not price sensitive. The patient, somebody else is paying. The insurance company's paying, and so competition. Come to our hospital, you'll get your MRI quicker. Whether or not your MRI will improve treatment, you'll get it, or I'll go to that one. So competition drives up costs. I think when it comes to clothes, automobiles, smartphones, there's no question that competition is a good thing. You get a nicer jacket or you get a better smartphone because people are competing for your dollars, and that's a good thing. When it comes to healthcare, I think there's good evidence that competition is not a good thing. A market in healthcare is not a good way to get optimal allocation of healthcare resources. It's undoubtedly the best way to get optimal allocation of consumer goods. But I don't think of healthcare as being like another consumer good.
Don't clap yet. This book records a art exhibition that is being shown right now in our gallery. It's open right now for all of you. But this book is not yours. This book belongs to our speaker today. You want a copy, you can buy one. But since the professor has done such a fantastic job, don't you think that I should present this book to him?
Thank you very much. Good, thank you.